reset here. Again, I'm a spine surgeon here in Dallas, Texas. I go over different topics. The two different topics I'm going to go over today, one is a laminectomy, and I got a spine model here. The other is spondylolisthesis. So going over that one more time. Look, it goes bone, disc, spondylolisthesis, big fancy Greek word for when one bone is sliding forward on that. There's 6 different types. The overwhelming majority of them are 2 types. A degenerative one, that's where you get severe bony and joint arthritis, tissue arthritis in these joints. So if this is the spine, you get such bad arthritis in these joints that they just don't lock into place and they almost jump on each other. That does not at all mean you need surgery. And even if you did need surgery, that does not necessarily mean you need a fusion, to be fair, especially in the degenerative type. The degenerative type, fusing for the degenerative type, if it's stable, is a little controversial. And controversial doesn't mean it's bad. It means there's just multiple ways to get the person better. Our goal is going to be one and done, not to have subsequent surgeries, not to have other issues. So there's really not too much debate on how to get you better at that exact point. And maybe for the 6 months, 6 years later, we're kind of looking for the next 10 years later. Now, the other type of spondylolisthesis, and this is the one that's been really popular in the news recently for very obvious reasons, is the isthmic type. It's one of there's the fracture here in the back. So that fracture in the back here is at the pars, Greek word for this back part of the bone. And that's something that like 18-year-olds, 20-year-olds, even 30-year-olds get. You can get it from trauma. You usually get it from hyperextension injuries. That specifically is my favorite thing to treat. You don't necessarily need surgery just because you have it. But once you have it, once it's symptomatic, and what does symptomatic mean? It means you've lost the disc material here. And so just like those medieval guillotines that come down and are chopping your head off, it's kind of doing that to this nerve. You've lost the disc space, and it's coming down and hitting that nerve. Yep, Amberly, pars fracture. You nailed it. P-A-R-S. I forget exactly what. I think pars is like a wing of the bone. It's a Greek word for wing, maybe. I'm sure someone could Google it and tell me right here now. I just kind of forget exactly what that Greek word means. But the reason I like the pars variant specifically, again, it's usually younger patients. Well, great. Younger patients always do pretty darn good, right? 2, there's not really debate on how to treat it. Just like if you fractured your hip bone or certain things in your skull or certain other bones, you need a fusion to fix a fracture. That's rods and screws. And that might sound scary. You're like, oh my gosh, I've heard someone got rods and screws and they did terrible. That's just such a broad statement. That's like saying I heard someone brought their car to the shop and the car never worked the same way. You don't know how that car went in. You don't know how many levels. You don't know the skill level of the person that did it. So it's a whole wide variation. But in general, an isthmic spondylolisthesis, fancy word for a fracture in the back that leads to instability. Once it needs surgery, and that's a different debate I'll get to later in terms of who needs surgery, who doesn't. Just because you see that term on your MRI or X-ray does not mean you need surgery. But say now you need surgery. How do you fix it? In 2024, the gold standard is a spacer or a cage in this disc space placed right here. So it goes either through the belly. You could do it through the side, depending on the level, or you could do it through the back. And then the rods and screws in the back to stabilize it. If it's an isthmic, if it's a pars fracture, you've probably already lost all the range of motion there anyway. You're probably already bone on bone. That's why you're symptomatic to have surgery. Going through the front, going through the back, it's a little bit of a debate. And I'm not going to sit here on my high horse and just say which way is better than the other. Some of it is based on the region and the surgeon. No, because he's not home.
Yes, he says. He came and knocked at my door.
Okay, you can go then. Sure.
How much minutes?
30 minutes. Sorry, that was my little love my life 6-year-old boy is asking if he can go to his neighbor's house, but I thought they were out of town. But he says that he's at the front door, so and then he asked if he can go play Minecraft. He's a very good little kid. Okay, so let me refocus here. Going back to the isthmic pars fracture we were just talking about, bone, disc, bone. That's when this comes down. This is getting squeezed. You need to put a spacer in here. You don't have to, but there's many studies that show putting a spacer in here and the rods and screws improve fusion rates, lessen the need for a subsequent surgery because you get lordosis back, and it has better opening of these nerve tunnels. In terms of going through the front, going through the belly, or going through the back? It's a little bit debated. One of the best studies on that is actually from a spine surgeon that I'm extremely excited to actually just moved to Dallas, Texas. It's a guy named Andrew Simpson. He did this study when he was at up in Boston with his team, and they found for patients that have the pars fracture, do patients do better from the cage and the rods and screws going through the belly or all from the back? And in that specific case, they proved that patients had higher satisfaction rates and improved outcomes when you go through the belly. Look, I'm not going to sit here and, again, tout that too much in terms of belly through the back, because there's many regions of the country that don't have the vascular surgeon to go through the belly. There's many hospital institutions where their vascular surgeons are doing stents and doing endovascular surgery, and so it's not very reliable for a spine surgeon to get their services for a case. So I'm not going to at all say if you're at an academic center and they can't get the vascular surgeon to come over and help them, whereas in private practice maybe it's easier. Different argument. Either way, having a spacer in there is a big deal. So the other type is degenerative spondylolisthesis. That's the second or the first, however, what order we're going in, of the 6 different types. That's this thickened tissue. If it's unstable, one bone moving over the other really bad, it does need a fusion. If it doesn't have the instability, it's a little bit of a debate. Okay, I'm going to go ahead and take a little pause here, and I'm going to just answer some questions, rapid fire. I'm going to try to be pretty quick on these. Again, I cannot give advice. And then the next thing I'm going to talk about after that, if you guys stick around, is this spine model here. And I'm going to tell you what removing this bone is called. And we'll go from that in a minute. So rapid fire from Kim. She has an S-curve, about 70 degrees. Sorry, that went too fast, but it also looked a little confusing, so maybe I can't do that. How much does it cost for you to have a herniated disc in your lower spine? How much does it cost for you? I don't know what that means. How much does it cost? I don't know how much it costs. I'm not sure what that question means. Okay, I'm over 2 on these questions. Next question, One Very Mad Dog. Dr. Donnelly, what are your thoughts on trigger spinal point injections? They're good, very low risk. Trigger points just kind of going into the muscle, putting some numbing medication. Ablation, good or bad? 2 thumbs up. Ablations are good. What are your options for bulging disc? Usually rest, time. Bulging disc itself don't necessarily need things. How do you know if you have spondylolisthesis? An X-ray. An MRI or CT could show you. CT is like way overkill, just because that's radiation. An X-ray is great. Sonopet, good for Mozzie. I've actually not used the Sonopet. I'm a big hardcore user. Pretty much every single decompression case I use the Bioventus one. That's that fancy ultrasonic laminectomy I do. Others can do it. I don't know why more people don't do it. I'm happy more people don't do it, because then I don't have to share my technology with other people in terms of the box at our hospital. What's my new favorite A-lift cage from Tracy? Tracy, I'm actually not going to tell you, because I swear to goodness, there was a live session like a month or 2 ago where I didn't even say it. I was holding up some product, and I got this crazy band that said I was promoting products without their permission, and I wasn't at all. So I don't want to say any brand names, because it gave me like this weird 10-minute ban. And I don't want to run that again, because that was ridiculous. Another question from Shannon Cox. I have osteopenia. Can I get a fusion surgery? You can get a fusion surgery with osteopenia. If you can improve that, then better. From Holly, God healed me. That's great. I'm very happy for you. I see Curry, you're sending me gifts. Don't send me any gifts on different social media platforms. I appreciate it. Very flattering. Save your money for other people on social media trying to make a living on social media. Again, I appreciate it, but save your money for for other people that need it more, to be blunt. So appreciate it, but just save it and give it to other people. Not doing this for that part. Tracy, I'll tell you when I see you. I just really don't want to say the name, because they gave me a little ban. African Kids in Christmas. Yep, that's a good one. From Queen Bee, 16 herniated disc. What would I do? I'm surprised you have 16, Queen Bee. Is that like an MRI of the neck and an MRI of the back and every single level? But maybe. Can you get a pain injection for neck pain? You can. Usually those are facet injections. From Duchess, thoughts on degenerative bone disease caused by past chemotherapy? I saw a lot of thoughts on that, but I don't have any recommendations. It sounds like that would be painful. It just depends. From BS, and then Hatley, what levels of spondylolisthesis will need to be surgically repaired? Well, let's jump back to that. There's 4 or 5 grades or types, or not grades, types, not types, grades of spondylolisthesis. When it's from 0 to 25%, it's grade 1. 25% to 50% displaced, grade 2, 50 to 75%, grade 3, 75 to 100, grade 4, and then grade 5 is like when it's all the way off. That's spondyloptosis, or grade 5. It can kind of go interchangeably, but it's not like if you have grade 1 from a degenerative, you're going to get all the way to grade 5 eventually. They're just different types. In fact, if you get to the grade, some 3, but mostly people that are grade 4 or even spondyloptosis, that's more of a teenager congenital thing. So think about that. It's not like you get that when you're in your 50s, 60s, you've had it so long. It's actually you were probably born with it. You were born with a defect, one of the 6 types, maybe the congenital type, and it just rapidly progressed in your preteens, teens, and it gets to that point. It could even be in your adolescence. So getting spondyloptosis in general happened really early in life. Maybe you didn't know it and got treated later in life, but it's not necessarily that it just like starts at that grade 1 and then rapidly throws off or slowly throws off over the span of like 40 years. Okay, so that being said, treatment's not really based on what grade it is. The type of treatment might be, but do you need treatment or not? Treatment is not based on, oh, you have a grade 3, you better fix it. I've definitely seen several people with grade 3s or really bad grade 2s, and like they're doing totally fine. And maybe it was an incidental finding, and that's what they're coming and talking to me. If you're doing good, you're doing good. If we can avoid surgery, if you can avoid it, great. You don't know what the world's going to be like in 5, 10, 15, 20 years. So if we can avoid things, let's avoid them until you need it. With that being said, most of them are grade 1 and grade 2, and most of them, if they're grade 2 or grade 3, do get a fusion procedure. From Stuart, drain or no drain with ACDF. It depends on the levels. If I do 3 or 4 levels, I don't really do many 4 levels, but 3 levels, drain all the time. 2 levels, usually I do a drain. 1 levels, I don't do a drain. And that's the same thing with disc replacements in the neck in terms of leaving a drain. Interestingly, drains do not change post-op complications or hematoma rates. Bilateral spondylosis, likely to progress to spondylolisthesis from Amber. It's maybe. The actual rate's a little unknown. Like how many people have that fracture and haven't moved and we just don't know it. More likely than not, it was. Grade 2 spondylolisthesis, weakness in the left leg, increasingly getting worse. I fear I may need surgery from Brittany. Yeah, I fear you might also. If you have weakness in the leg, then goodness gracious, I wonder what, people say they're afraid of surgery. Well, very likely surgery is going to be great and you're going to do wonderful. If you have weakness right now and you're afraid to talk to a doctor, it's more likely that's going to keep getting worse and you're going to have self-induced paralysis. So I do encourage you to reach out to someone. I could give you my info, but I'm not wanting this to be like a marketing thing. So you can always direct message me and I can connect you with my staff, but this is not why I'm on here. From Pilly, good evening, doctor. I have spondylolisthesis. I've had one doctor tell me that, sort of cage to the back because of what he sees on the MRI send. Another doctor says he will try to go through the side. And if he's not able to, he'll go through the back. I know without seeing my MRIs is difficult. Can you comment on your initial thoughts? Thank you in advance. In general, I always favor going through the belly or going through the side when possible. You can't go through the side at L5S1 just because your hip crest is too high for everybody. Many people, you're at 4-5, your hip crest is too high, so you can't do it at 4-5 in less than half. But some people you can't do 4-5. So it sounds like maybe yours is at L4-5. It sounds like that's sometimes what I tell. Usually I don't even tell patients just because even if it's a little high, I know I can get it. But there's every now and then I'm like, I really don't want to have to go through the back totally. So I tell them, like, look, if I can't get it through the side, if it seems too dangerous, I use neuromonitoring, a little probe to test all the nerves. If I just can't get a good corridor, I'll call it and we'll do it all from the back. That sounds like what it's going on right there, Bill. Yeah, 4-5. So someone's mad I've skipped their question from AA or ARG. That's kind of a funny name, ARG, since you're mad that you skipped your question. Let me get to your question. L4, L5, crushed, have spinal stenosis, please help. Well, I don't really think that's even a question, to be fair. So if it's crushed and spinal stenosis, I know it wasn't a question there, but that would be if you're looking down the tunnel of the spine. There's different things that can squeeze all the nerves right here. If it's the joints, the facets, they can all push in this way, push in the nerves this way. A disc herniation would push this way, so you can have the combination of the two. And if you have spondylolisthesis, the bone's moving, that kind of crushes them in both ways. One answer, ta-da, I told you I'd get to this model eventually, is something called a laminectomy. It's amazing how many people I see that are like terrified of a laminectomy. I don't know. I do know the video that's out there that scares people away from laminectomies. But I mean, I don't know what other access you guys have to spine surgeons, but you ask any spine surgeon, and I know you're gonna think they're biased, like what's like the best surgery patients do the best from, and it's like 1 and 2 level laminectomies, even 3 level laminectomies. It's just they're super straightforward, they're relatively easy, and patients just bounce back really fast. And it's just amazing how many people I know need a laminectomy or even offer laminectomy, and they go seek out some other crazy treatment or just deal with the pain or just suffer for multiple months. It's like, dude, laminectomy is so good. Anyway, moving past that, this is the laminectomy. It is removing. You don't have to, but there's just depends on the level and a couple other things. But it removes the spinous process. You could also remove this part. I sometimes just shave away some of it. And now you have this big opening cavity right here, and you can clean out all the arthritis in there, all the arthritis in there. Now, the most people are like, oh, no, I don't want to move that part of my bone. It's going to lead to instability. That's not entirely accurate at all. If you have underlying instability to start with, maybe. If you take too much bone, which is kind of hard to do, it's pretty super low rate, less than a couple of percentage points, just because spine surgeons know a lot better now. That's called iatrogenic. I can't put this back, can I? That's called iatrogenic spondylolisthesis. You could. Oh, my gosh. Great. But in general, taking this lamina, patients do great. I've done multiple L1 to S1, and they do great. Look, it's not a fusion. And what's the alternative? Not having surgery, which is an alternative. Like, if you're in pain, doing something like a laminectomy, and I use this ultrasonic tool. I think it's really good. I'm not saying that the burr, the traditional thing that spins, is bad or anything like that, but I use this ultrasonic tool, pops this area off, clean this out with tools called kerosins. 1 level, 2 levels, I'll let you go home that day. Just depends on where you're originating from. If you're flying from across the country, I'll keep you overnight. Different things like that. That being said, I do appreciate the likes and shares. If we can get this up to 10,000, that would be wonderful. If you want to share this to any of your colleagues so they can jump on and see it later, that'd be wonderful. I do have all this on YouTube as well. So later I will post this to YouTube if you want to go back and listen to anything I said. I know I go a little fast. Sometimes it all cuts out. From ARG, I'm not mad, all good. Okay, sorry. My name came from when I turned on 60. I don't know what that means. Does a laminectomy compromise the spine? Not, I mean, it takes this part of the bone, so I don't know if that can consider compromising it, but it's really just opening up. It's like if you're sitting in an office, I'm not in an office now, and you have those tiles above you, those really generic tiles, and there's 7 tiles that go across. I'm just taking 1 or 2 of them and then coming in there and cleaning out all that junk in the office and then going. I don't leave anything else over the top. I don't. No one does. I guess you could leave some like amniotic patch. Those things are like $4,000 and kind of a little hocus pocus, but I still like them, but they're $4,000. But you don't leave anything on the top. I tell people, even if Dwayne "The Rock" Johnson, who I was able to shake his hand one day, came and punched you in the back, he's not going to get down into that cavity. You have so much muscle and tissue covering it, and then it's just a small cut. So if you like, if this is probably life size, maybe it's just a tad smaller. Oh. Okay, don't look at that. That's not what's going to happen to you, I swear. Oh my God, now it's all just falling apart. Okay, so with that being said, if you can imagine how you have this little cut out into the bone right now, it's like you have all this other bone on top protecting it. So you're not going to get down to that area. I do see why patients would be afraid of that, but it's like I tell them, and they're like, well, I'm a little worried, and then they avoid spine surgery, and that's fine. You know, if we're debating other types of surgeries, I agree. Get second, third, fourth opinions. Still get a second opinion on a laminectomy, but they're just so straightforward. I do encourage anyone to direct message me. I cannot give any medical advice, but that will be my one plug. The number one thing patients don't have on their new appointments, and I feel like I stress it, and they're like, I know you told me, but I was just seeing if it mattered, and it does, is x-rays. Everyone has their MRI because you go to a facility, you get your MRI on a disc. You need to go back to your spine surgeon, get your x-ray on a disc. If they say, oh, they can't burn the x-ray, just remind them that, you know, we've all been burning CDs back when Napster and LimeWire were a thing. So burning CDs is a very common, easy thing to do. Don't be told otherwise. How about that? Henry D, appreciate that comment. Very nice. Pale Rider, good to see you also. What about a CT and an MRI, no x-ray from Dory? Those are also good, but got to see x-ray. Because the key thing, if you think about Dory, when you get your MRI or your CT, you're laying down. Good, fine. And you're like, okay, why does that matter? Because I need to see your spine with gravity. I need to see what happens when you're standing. And as importantly, I need to see what happens when you lean forward and when you lean back. And believe it or not, this is why orthopedic spine surgeons have a widely different view on how to treat the spine on certain things. I need to see your hip joints. You know, if any orthopedic spine surgeon's probably done, I don't know, 300, 600 hip replacement surgeries, part of our training. And so I kind of know what to look for, right? And I know what to listen for. There's many things in the spine that could go to your hips. There's many back pain things that you might think is your spines. That's your hips. So I would say almost every single clinic I have, there's at least one patient I'm sending to a hip doctor to get their hips looked at. And I don't know, maybe I'm making this number up. 50% of them, the hip doctor's like, it's not the hips. And they just do an injection there and it gets better. But goodness gracious, one of my best friends here is a guy named Christopher Odom. He's I don't even know how many of my patients he's operated on because they think they have back pain. I had one guy from Lubbock. He might be watching now. I know he follows me on social media. He came to see me, drove in. I was like, listen, man, I know he can get you better. I was like, it's not your back. And he was shocked. And I was like, it's your hips. I'm positive. Stepped out, called my buddy Chris Odom. He went to go see Chris Odom that afternoon, got hip surgery like 4 weeks later, wrote a ridiculously funny 5-star review on Chris Odom's Google. If someone gets super bored, you'll see it. I mean, you'll know, like, dude, this is the guy. They'll say, I saw a spine surgeon. He called his friend and sent me to see Odom, and the guy's feeling like $1 million. So food for thought. I know it's a little tangent, but that's why your MRI and CT just aren't necessarily enough. I need the x-rays because I want to see your hip joints. I want to see gravity, how your bones are moving. Very big part. MRI is key. MRI shows me the nerves. I do have to hit one button. No one leave. 1 second, everybody. I have to hit one thing here. Okay. Sorry. Every now and then I do have to check my text messages. Believe it or not, I do have a life and a family outside of that, so I have to check a couple things. I also have one of my little kiddos taking a nap, so I have to check in on them. So I'm going to do this maybe for another 5 minutes, just 5 minutes. Actually, maybe just 2 minutes here. You can always follow up on alerts. I always like to end these by just giving a couple advice in different cities. And so I'm going to run here actually just to sum up. I know I'm all over the place with this, but I'm going to run. The thing that I like to always end my sessions with, if I can remember, is if you tell me what town or city you're in, I'll tell you if I know a spine surgeon in that city. Again, I'd love it if you jumped on a plane and came see me here in Dallas, but economically and time-wise, that's not realistic for everybody. So if I've gone to residency with someone, med school, fellowship, goodness, the amount of people I've met in my life, I'd love to just, hey, there's someone in your neck of the woods. You know, maybe if I'm the best spine surgeon, maybe they're the second best spine surgeon and they're worth seeing. You know, I'm obviously kidding. Now, people that are going to say Waco and Fort Worth, goodness gracious, I'd say come see me. If I don't know anyone in that city, just direct message me. Sometimes I forget people's names. London, I don't know anyone in London. I'm sorry. California, I don't know like where all these cities are in California. I'm a true Texan at heart, and that's just California, just like the Northeast is the Northeast. But in Los Angeles, he doesn't take Medicare, but a guy named Alexander Gasem, Ghasem, is one of my best friends. We're in a group chat about spine surgery, so we share cases. I hear his thoughts. Coming in hot here. So Pennsylvania, the whole state, goodness gracious. Okay, Pennsylvania has the world-famous Rothman Institute. So if you're in Pennsylvania, somewhere at Pittsburgh, anywhere, Philadelphia, New Jersey, I would go see one of 3 or 4 guys. You ready? I would go see and write this down, Christopher Kepler like the Kepler telescope or Kepler something. You can also see Jose Canseco, and no, that's not the baseball player, but those are easy names to remember. And Alan Hillebrand, Flower Mound. There's a guy named Chester Donnelly who's in the Addison area. He's maybe worth seeing. Des Moines, Iowa. I don't know in Iowa, sorry. Greenville, South Carolina. I don't know anybody. I'm not in Houston. I'm in Dallas, Arkansas. Direct message me to Arkansas. I have a buddy who's at UMass. I've only met him at one course, so I kind of forget his name, but I swear we're friends. Colorado Springs. I only know one person in all Colorado, and he's very good. His name is Michael Galizzi. He's in Vail at Stedman, Galizzi. So if you're anywhere in Colorado, I recommend him. But again, I'm sure there's someone else I just don't know of. and Buffalo, New York. If you want to go to the city, a guy named Alexander Butler, Dr. Butler, super handsome, super nice. He's worth the drive. Just don't bring your wife because he's a super handsome guy. Salt Lake City, University of Utah has two famous spine surgeons. I'm just totally on the spot blinking on their name. If you're in Tulsa, Jeff, goodness gracious, I really encourage you to drive down and see me. San Diego, Gregory Mundis is fantastic. I don't really know anyone in Canada. I don't see patients from Canada, unfortunately, just so you know. Honestly, it's because I want a study done, and just the way y'all's healthcare system, it takes you guys like 8 months to get that study. It's just too hard. Amarillo, I've probably operated on 10 patients from Amarillo. I'd come see me. My mom also went to high school there, so that's a nice connection. St. Louis, surely somebody I could think of. Boston, the guy I used to recommend in Boston just moved down here to Dallas, so I got to find a new person in Boston. How about that? Naples, Florida. I know someone in Naples. His name is Michael Valenci. I'm saying that wrong. If you direct message me, Naples person, I'll pull up his name in my contacts. I just can't pop out. Anyone in Knoxville, Tennessee, Knoxville, anywhere like that, I would go see Dan or Daniel Wells. Daniel Wells, super ethical, super good. Is Dr. William Butler at Mass General? No, William Butler's at Lenox Hill. He's at Lenox Hill. If you're in Alabama, I'd come see me. Boston, Dr. Paul Glazier. Yeah, I've heard that name. I think Paul Glazier is pretty good. I don't know. Tyler, Texas. I would drive straight over to Dallas if you're originating in Tyler, but I'll just leave it at that. Arkansas, I know somebody. I probably do look at my friends before I do one of these things. I keep telling you I forget their names. Shows you how popular I am. Okay, Jacksonville, Florida. A guy named Sebastian Rivera is there. Sebastian Rivera. He's great. I've trained with him. Nope, I use Dr. Butler at Mass General in Boston. Okay, that's good. That's good. That's not the same Dr. Butler I'm talking about, but good. Oh, Chicago. Yeah, Chicago, Illinois, anywhere, Michigan. You got to go see a guy named Sri Divi. His legal name is Shrikant Divi, but S-R-I and then Divi, D-I-V-I. If you're in Orlando, Florida, go see Sebastian Rivera. Albany, New York. Again, I'd go see my buddy Alexander Butler. So, Michael, you ask, is the TLIF the usual procedure to address 4-5 spondylolisthesis? It is definitely a typical procedure to use, but there's 3 different fusion surgeries. They might go from the back, like you're having. They might go from the side, or they might go from the belly. San Antonio for monologic, I'd just come see me. I'm not too far. I think I'm worth a couple hours to your health. Pittsburgh, I would go see Jose Canseco. He's in Philadelphia. It's worth the drive across the state. It really is. Nashville, go see Julian Lugo Pico. Hyphenated last name, Lugo Pico, or Pico Lugo. But Julian Lugo Pico, he's at Vanderbilt. Super smart guy. Kentucky, I would go see, he's in Tennessee. Close, but not super close. Daniel Wells. I don't know in Detroit. Rexford bilateral pars fracture defect. Go see my YouTube video. We just talked all about that. It's if you need surgery, you need an interbody fusion. That's something that recently became popular with the current news stuff. But you can go see my things. Okay, everybody. So, Pilly, yes, how long will the operation take? It just varies. You can between an hour and a half and 4 hours. It really just varies on spine surgeon stuff and how they do it. So I do appreciate everybody. I know I had a lot of cities. I said I forget the person's name. Honestly, I don't hang out with anyone anymore. Just my children, and that's all that matters. So I forget a lot of my friends' names, but they're in my phone. I could search it, and I could tell you their name of someone I recommend at city. Just reach out to each other. You guys are great resources for each other, and you could direct message me, and I can just pull up his name, and I'll just text you there, but I cannot give advice. All right, everybody, please hit the follow and then hit the alerts so that way next time I'm on, it gives you an alert. That might help you be able to ask your questions right when we're there.